There is no doubt osteoporosis and the consequent fragility fracture occurrence is an Australian public health problem. Currently, more than 900,000 Australians are diagnosed with OP, 1 in 3 of these women and 1 in 5 of these men experiencing an osteoporotic related fracture, with 90% of these resulting from a fall. Hospitalisation due to osteoporosis is a growing issue, as seen in Figure 1, with 2022 having the highest admission rate since 2011. This has a huge effect on the client's health, status, and quality of life. My name is Stacey Thom, a current student EP here to present to you the role of an exercise physiologist in OP management, including evidence-based exercise prescription, contraindications and precautions, assessment strategies, and client safety. I too will discuss the need for an EP to support the client beyond exercise alone. AEPs work in a multidisciplinary environment. They can refer clients onto allied health professionals to assist in areas they believe need attention. For example, they can refer a client to a GP if they're concerned regarding their health. This ensures the highest level of care. AEPs have been educated in high-level chronic condition physiology and are experts in exercise delivery. Combined, they have the power to treat chronic illnesses safely and effectively backed by science. They can treat clients' osteoporosis as well as any other comorbidities, as all chronic conditions can be prevented and treated with exercise. There are 2 key target adaptations of exercise for osteoporotic clients. 1, resistance training and weight-bearing impactful exercise, and 2, fall prevention exercise. Moderate to high level intensity of resistance training is necessary for improving bone mass. Heavier weight and high impact places a diverse range of loads on the bone due to the pulling actions of muscles and increases the effect of gravity. This stress triggers a cellular response where osteoblasts produce more bone. Moderate to high intensity correlates to working at 75 to 85% of a client's 1 rep max. Working at this intensity for 2 to 3 sets and 5 to 8 repetitions, 2 to 3 days a week is best for adaptation. Exercises should target muscle groups attached to or crossing the spine and major extremities of the body in a standing and therefore weight-bearing position. Weight-bearing impact exercises such as jumping have osteogenic properties due to the stress they place on the bone causing remodeling. Intensity should be moderate to high based on the client's ability. This correlates to 2 to 4 times body weight, which is ideal for bone remodeling. Training should occur 3 times a week with 50 impact loads total per session. It is proven lower intensity, high impact exercises such as foot stomping also have osteogenic properties and hence can still be prescribed to high fracture clients. However, technique must be supervised. Fall prevention exercises are critical as 90% of osteoporotic fractures are due to fall. Muscle strengthening in a functional approach targeting lower limbs and core improves balance, coordination, gait mechanics, and stability. This type of training should occur 3 times a week, accumulating to 3 hours, and the intensity should be progressively challenging. Types of exercise include functional stability, dynamic and static balance, anticipatory control, and reactive balance. All client programs are evidence-based and developed with the individual's needs, goals, and limitations in mind. This ensures client-centeredness, which directly influences adherence to an exercise program, while also developing an individual's self-efficacy and general exercise enjoyability. There are no specific contraindications to exercise for osteoporosis clients, however, safety is critical. Exercise precautions include thorough form education prior to exercise, as twisting and transitioning between positions have a high fracture risk. Understanding and modifying programs to suit the client's abilities and condition severity is critical and is something exercise physiologists are highly knowledgeable about. AEPs will conduct objective tests on clients regularly to assess progress and ensure safety. Strength testing, including repetition maximal testing and grip strength, ensures a client is becoming stronger while also ensuring prescription is suitable. Psychological factors can be assessed to ensure mental progress, for example, assessing fear of falling using questionnaires. Other objective measures such as blood pressure, and ECGs can be utilised to ensure client safety, specifically if they have other comorbidities such as hypertension or cardiac conditions. AEPs utilise the FLAGS model to guide their decision making. This model emphasises a psychosocial approach to identify factors that could impede a client's recovery and independence additional to their biological health. They are also trained in motivational interviewing. These conversation styles allow empowerment of a client that they can make behaviour change in relation to exercise and lifestyle modifications. It encourages them to identify their own reason for change, the barriers to making this change, and how they can overcome these barriers. Setting specific, measurable, achievable, relevant, and time-bound goals provides direction and promotes behaviour change. Motivational interviewing and SMART goals combined improves treatment adherence, optimising exercise physiology interventions. The need for exercise delivered by an AEP for the treatment of osteoporosis is paramount. An AEP's knowledge in exercise delivery, client-centered approach, high regard for client safety, and multidisciplinary collaboration provides the best treatment for osteoporotic clients. improving not only their health but their quality of life.